I put on purpose clinical applications because I will not mention any research or anything. Directly the things we are using in the clinic, the tests we are doing now routinely, and the treatments that are used in the clinic now. Okay, so what's cancer? Uncontrolled cell growth or tumor or cancer. Okay, uncontrolled cell growth. So first, uncontrolled. First keyword is the control. What's controlling? What's controlling the cell? Good. Tumor suppressor genes. This is the reason why we are telling these are tumor suppressor genes. They are controlling the cell, basically. First, repair pathways. Again, another, it is division, especially, of course. Yani checkpoints, let's say. Repair and checkpoints, especially. So the genes playing role in the repair and checkpoints are basically tumor suppressor genes. Okay? Second, uncontrolled cell growth. We solved the issue with the control. And by the way, these genes are working. These genes are suppressing the tumor suppressor genes. So there should be mutations inactivating the genes, right? If the gene work, then there will not be tumor, or tumor will not be successful. They should be inactivated or removed from the cell. This is the difference. Tumor suppressor genes are mainly playing role in repair and checkpoints, and they should be inactivated for tumor to grow. Second, growth. What is inducing? What is triggering growth? What do we need? Yes, and oncogenes come. Oncogenes promote division, growth, survival, and other things. This is the reason why we are mentioning. I mean, all of them has some roles. Oncogenes are activating some pathways to promote tumor. They are serving the cancer. And they are inducing, promoting growth. So they should be activated, right? If they are inactive, then there is nothing. There is no meaning. Tumor suppressor genes should be inactivated. Oncogenes should be activated for a cancer to grow, to promote. Okay? Let's continue. So there are different terms. It's better if you know them. You are doctors. You will hear them in the clinic. You will hear them in your career. So first, hereditary. When we say hereditary cancer syndromes, what do we mean? When we say familial cancer, what do we mean? When we say sporadic cancer, what do we mean? So a syndrome, basically, when we say a syndrome, the patient has a specific pattern of clinical features. First, there is a specific pattern, then there is a reason. I mean the reason, for example, BRCA. There is a mutation, there is a genetic reason. If there is a specific pattern and the reason, this is a syndrome. So, for example, hereditary breast ovarian cancer syndrome has a specific pattern and a gene. For example, BRCA1-2 genes and mutations. Okay? Familial cancer is different. It is covering also hereditary cancers, but different. For example, a family is coming to us, 10 patients in the family. In the same family, 10 patients has breast cancer, same type, same age onset. When we test the family, we find nothing, no mutation. This is familial cancer, okay? The cancer seen in the family for generations, 3 generations, 4 generations. We couldn't find anything, any reason, doesn't matter. Still, it is familial cancer, okay? But, for example, if we detect BRCA1 mutations, then it becomes syndrome. Then it becomes hereditary breast ovarian cancer syndrome. And if you find nothing, if it is not familial, if there is no genetic and nothing you can find, then it is sporadic. And most of the cancers are sporadic, of course, growing. So it's like a basket. Still, cancer is also a multifactorial polygenic disorder. So most of the time, it grows. There are many factors that helps cancer to start and grow. Second term, germline and somatic. These keywords are also very, very, very important for you to understand for your career. The whole career you will use this information. Germline, we get them from our parents. these mutations, we carry them in all our cells. It doesn't matter, skin, blood, nail, hair, it doesn't matter. All the cells are carrying these DNA and these mutations. And we inherit them to the next generation. Okay? These are germline. Germline from birth to death. Somatic mutations are different. Somewhere in life they occur. They can disappear. In cancer, for example. You make the surgery, they disappeared. Okay? Only in specific area. Only in the cancer, for example, these mutations. Not in other cells. Only in the cancer. They occur, they disappear. We don't inherit them to the next generation. These are somatic mutations. So you will better understand as we continue how they are important and connected to each other. Let's go. First, germline mutations. There are syndromes, of course, related to germline mutations. When we say syndrome, as we mentioned, there is a specific pattern and there are genes, okay? So you see many syndromes here. You will hear all of them in the clinic. Hereditary breast ovarian cancer syndrome, very popular. There was a breast cancer month. Last month, you heard everything related to breast cancer and other things. There is also Lynch syndrome, mainly related to colorectal cancer. Familial adenomatous polyposis, codon, lymphoma, multiple endocrine neoplasia. So the genes responsible for hereditary cancer syndromes are tumor suppressor genes, mainly playing role in DNA repair and checkpoints. Okay? So for example, hereditary breast ovarian cancer, Lynch syndrome, DNA repair. The other ones, checkpoint. Okay? So germline, tumor suppressor, hereditary cancer syndromes. They are all connected to each other. Okay? It's better for you to understand if you think like that. So hereditary breast ovarian cancer syndrome, the most important genes, as you know, BRCA1, 2, of course, they have been discovered in 1994, by the way, 30 years back. But they've been popular with Angelina Jolie, as you can imagine. They haven't been popular until Angelina Jolie. So you also know Angelina Jolie. She has preventive surgeries, mastectomy, and also TAH-BSO. You know what is TAH-BSO now? We discussed in the tutorials. So there are different genes here. BRCA1, 2, also ATM, PALB2, checkpoint. There are many genes. Mainly, they are playing a role in DNA repair. They are homolog recombination repair genes. Okay, mainly repairing double-stranded DNA breaks. Okay, so repair, tumor suppressor, hereditary breast cancer. I am repeating also the previous slides for you to better understand. Still, we are discussing tumor suppressor genes. We are on the germline side. Okay, these genes are playing role in DNA repair. There are many genes, of course, playing role in this double-stranded DNA repair. There are also treatments, as you will see, PARP inhibitors. And I will try to also make it easy for you. So these genes, homolog recombination repair, plays a role in double-stranded DNA repair. Okay? So if they lose their function, if they cannot repair double-stranded breaks, then other mechanisms, other repair mechanisms are activated in the cell as compensation. Okay? So for example, one of the other repair mechanisms is single-stranded DNA repair. And PARP, as a protein, plays a role in this repair. So double-stranded repair is inactivated by BRCA mutation. And you also target another alternative pathway in the cell with PARP inhibitors, then the cell dies. Simple logic. Okay? You don't allow cancer to use alternative repair pathways, cancer cells. This is the logic. We don't target with PARP inhibitors directly BRCA or ATM or genes playing a role in the homolog recombination. We target alternative repair pathways. Okay? Let's continue. So, this will be confusing for you, but I will make it simple again. DNA repair, when DNA repair is disrupted, there will be mutations. Similar logic, okay? So the cell cannot repair itself. There will be mutations. There will be result. There is a reason, there is a result. You can check the reason, BRCA mutations, or you can check the result, Result is homolog recombination deficiency scar. So according to mutations, accumulation of mutations, there will be some changes on the DNA. They are not BRCA. They are on the DNA, on the genomic region, on different regions, there will be, let's say, mutational niches, or let's say in the, for example, satellites and other parts, there will be different types of mutations. You can also check them. You can check the reason, you can check the result, okay? I will not go into detail, I'm continuing. Lynch syndrome, another repair mechanism, mismatch repair. Okay, you see the genes here. This is a mismatch repair, mainly playing role, mainly the cancer is the colorectal cancer. Increase for colorectal cancer. And then endometrium and then gastric cancer. And of course, they are DNA repair genes. They can increase the risk for any cancer in the body, okay? I will go back and show you, for example, you see many syndromes here. They are all increasing risk for breast cancer, of course. They are playing role in the DNA repair and checkpoints, even if they don't have breast cancer in the headline, okay? There are some specific patterns, okay? Lynch syndrome is increasing risk, specifically for colorectal cancer, endometrium cancer, but it doesn't mean it doesn't increase the risk for breast cancer or lung cancer. They are increasing risk. Same logic, when there is a repair disruption, there will be results, of course. There will be results, and this result is instability. There will be, again, mutations, especially in the repeat regions, satellites, as we mentioned. So microsatellite instability is another term you will hear in the clinics very frequently. It is a result of the deficient repair, basically. Okay? Again, same logic. You can check the reason, check the mutations of the genes, or you can check the result, microsatellite instability. Or in homolog recombination repair, you can check the genes, BRCA1-2 mutations, or ATM-PALB2 check2, or you can check the results, HRD scar. So when interpreting these mutations on the germline, we are using the American College of Medical Genetics standards and guidelines, and we are classifying the variants, pathogenic like the pathogenic, WUS like the benign. Of course, we don't report WUS like the benign. They are not very important. We report only pathogenic like the pathogenic. Since they are important, they will be important to follow the patient for treatment for other things and screen the family. And we classify the variants. Of course, we are using in silico tools, artificial intelligence and protein structures, 3D and other things to predict the effect of the variants. Still, we are on the germline side. On the somatic part, it will be different. So let's go to somatic part. Now the cancer started. There is a cancer. We get the cancer, okay? So the genes activated now are oncogenes, promoting the cancer, serving the cancer, to grow, to promote, to escape immune system, to develop treatment resistance, okay? Now the things are changing. So there are different ways to analyze. Golden standard is the tissue, of course. And when you get the tissue, you can analyze it and everything is perfect. You get the mutations directly specific to the cancer. Or we can also do the liquid biopsy. I will explain the logic of the liquid biopsy. We get the blood, but we analyze the circulating tumor cells in the blood. Okay? This is different. I mean, on the germline side, we get the blood. So in the blood, there are erythrocytes, thrombocytes, leukocytes, lymphocytes. Erythrocyte, thrombocyte don't have DNA. So we collect lymphocytes, leukocytes on the germline side. When trying to determine the mutations on the germline side of the syndromes, we collect lymphocytes, leukocytes, and analyze them, analyze the DNA, okay? Here, this is different. In liquid biopsy, it is different. We are targeting directly circulating tumor cells. So we are separating erythrocytes, thrombocytes, lymphocytes, leukocytes. We are separating all of them. We are only targeting plasma. In the plasma, we are looking for specific circulating tumor cells. Okay? Tumor cells or tumor DNA, both of them are possible. This is different. Yani, we take the blood, but techniques are different. We are looking different parts. let's continue. So it's used in many ways. Basically, an liquid biopsy can also be used for diagnosis, treatment, prognosis, treatment resistance, and other things, but mainly in the clinic. Now we are using to determine specific targets and to determine therapy resistance. Okay? Mainly we are focusing on that, especially therapy resistance, of course. So there are also different terms, tumor burden, tumor mutational burden. You will hear them in the clinic again. Similar logic. So when the DNA repair mechanisms are disrupted, mutations will increase, okay? Tumor mutational burden means all the mutations in the cancer, basically. All the mutations in the cancer. So if there's a problem, the mutations will increase. If the mutations are high, there will be opportunity for immunotherapies. Also in the microsatellite instability, there will be opportunities for immunotherapies. I'm going quickly, circulating tumor cells, and just comparison for you. NIPT, non-invasive prenatal testing we are doing, for example, it's the same logic. The bigger the baby, the more fetal DNA you can find in the mother's blood. The bigger the cancer, the more cancer DNA you can find in the patient's blood. Okay? This is also somatic analysis of the genes, of the mutations of the cancer. So pathways are very important, of course. As I mentioned, the oncogenes are mainly belonging to some pathways, activating the pathways and promoting the cancer, serving cancer in growth, in therapy resistance, in invasion, metastasis, and other things. So mainly the genes you see here, EGFR, MET, HER2, FGFR, and other genes are oncogenes, first of all. And they are on the pathway, receptor tyrosine kinase pathway. Cancer is somehow trying to activate this pathway because it's serving it. So we are using different techniques, PCR, digital PCR, NGS. We prefer NGS, of course. Yeah, and the most comprehensive test. I will explain why. I am passing this part quickly. We have got limited time. And EGFR, LK, ROS, BRAF, HER2, MET, RET, and TREC. All of them are belonging to the oncogenes and activating receptor tyrosine kinase pathway and serving the cancer. So mechanism of resistance, it could be anywhere on this pathway. This is the receptor tyrosine kinase pathway. It could be anywhere, okay? This is the reason why we are trying to detect anything, any mutation. So if there is a mutation here, for example, in BRAF, it doesn't matter if you target these genes or other parts, because the pathway is activated from here. Either you target the mutated molecule or the next molecule on the pathway, basically. Let's go in breast cancer, HER2, estrogen receptor, PI3K, AKT-mTOR pathway is really very important in breast cancer. Generally activated, especially in breast cancer. Prostate cancer, similar, by the way, homolog recombination deficiency. I mean, the BRCA mutations are increasing ovarian breast cancer risk in females, increasing prostate cancer risk in males. Similar logic, again, PARP inhibitors can be used. I'm passing these parts. The interpretation is different here. The mutation of the interpretation of the mutations are different, belonging mainly dependent on the clinical trials, because you need to see if the mutation is causing therapy resistance or it can be targeted by a specific treatment. This is different. So when we say TR1, for example, of a somatic mutation, it means that there is a approved therapy for this specific mutation, and it is causing some kind of resistance. And let's continue. So early detection tests are started, not very common, but they started. Thank you. Okay, sorry.
I have 10 minutes instead of 5 minutes.